Good evening, everybody. My name is Zaf Nakwi. I'm a hand surgeon based in Manchester, and it's a great pleasure to host tonight's webinar. It's a little bit of a special occasion. We are now entering our second year of doing the Journal of Hand Surgery European webinars, and I'm very excited because we are going to discuss the enigmatic condition, which is Kienböck, and we've got a great panel to help us with that discussion. I'd like to introduce the panel. Our handling editor for tonight's articles is Michelle Borgsteins from Copenhagen. Our experts tonight, Professor Ian Trail from Wrightington Hospital, Professor Heinz Berger from Salzburg. I'd like to welcome our authors of the papers who have kindly and boldly come on to defend their papers, Dr. Pett and Carrie Allen from Washington University in St. Louis. Welcome to you both. And Professor Adesoke from Suhag University in Egypt. Welcome to you. And we will be discussing your paper in the second part of the evening. So before we get into the, I also welcome to our fellows who are going to present these papers, Antonia Hoyle from Sheffield, she's a TIG there, and Adam Smith, a TIG in Edinburgh. Thank you very much for your presentations tonight. Before we start the presentations, I'm going to share a case of mine, which is for everybody really to have a look at and to have a think about. I will pose the clinical case to you now, and then at the end of the presentations, we can then ask the panel and maybe you at home what your preference would be for my patient. So without further ado, I'll share my screen. I'd like to thank my registrar, Robert Cook, who's helped with the preparation of this. So my lady is 35 years old, or was 35 years old at the time. She had pain in her left wrist, dorsocentral, for 7 months prior to her presentation to my clinic. There was no history of trauma, and there was no improvement with physiotherapy or splintage. You can see the X-ray here. You can see the variance of the ulna there. And you can see in the lateral the morphology of the lunate and a little crack there in the lunate you may be able to see as well. CT scan, these were the images. You can see more clearly what's going on with the lunate there in the middle of those images. And the MRI scan showed the lunate to be pathological, as you can see there in both views. So I'm going to stop sharing and I'm going to ask for the start of the presentation. I'm going to go to Adam first, Adam Smith from Edinburgh, to give us the first paper, please, Adam.
Hi, thank you very much for the opportunity to present the paper this evening. The paper by Van Handel et al. Was published earlier this year and is entitled Medial Femoral Trochlear Flap Reconstruction versus Proximal Row Calpectomy for Kienböck Disease, a Morphometric Comparison. We know that there are very limited salvage options available when managing advanced stages of Kienböck disease in younger patients. Proximal row calpectomy is an option, but there have been some concerns about the durability of this procedure in younger, more active patients. The 2008 paper by Hawkins Rivers et al. Is referenced in the paper here, where concerns around a mismatch in the lunate capitate radius of curvature are documented, possibly leading to point loading and subsequent symptoms to the patient. The aim of this study was therefore to quantitatively evaluate the shape of the proximal capitate and the medial femoral trochlear and compare this to the shape of the proximal lunate articular surface. The author's hypothesis was that the shape of the proximal lunate would be more closely approximated by the medial femoral trochlear than the proximal capitate. To assess this, the authors set up a collaborative study between Washington University in St. Louis and the Curtis National Hand Center in the United States. 10 healthy volunteers were recruited between the ages of 22 and 35 years, and they underwent MRI scans on their ipsilateral wrist and knee joints. There was There was no further information given on patient demographics. Patients were excluded if there was any history of pain, injury, or previous surgery to either the wrist or the knee joints. MRI scans were then imported into a software program where grayscale values were used to differentiate between bone and cartilage. They were then rendered as 3D surface meshes, and the cartilage thickness of the proximal lunate, proximal capitate, and the medial femoral trochlear for each subject was measured. 3D morphometric landmark data was also used to map the articular surface morphology by placing landmarks along the perimeter of each articular surface. A 25 by 25 landmark mesh was then placed between these to map the shape of the articular surfaces. This can be seen here in this illustration taken from the paper. To match the radial to ulnar and dorsal to volar alignment of the articular surfaces, a best fit algorithm was used, which minimizes the sum of distances between all homologous surface points. The distance between 625 landmark points and a homologous point on the comparison surface was measured using a surface distance algorithm. From this, mean values were taken, allowing a comparison of articular surface similarity and also allowing direct comparison between individual subjects. Heat maps of intersurface distances were projected onto the proximal lunate of each subject to demonstrate the degree of congruity or dissimilarity between the surfaces. Separately, the knee MRI scan of a patient who'd recently undergone a medial femoral trochlear flap harvest was then used to make a 3D virtual negative template. By superimposing the post-operative MRI scan over the healthy scans, the articular defect could be used to template a simulated harvest in the 10 unoperated MRI knee scans. Overall, for 7 out of the 10 subjects, the medial femoral trochlear more closely approximated the shape of the proximal lunate than the proximal capitate did. This was indicated by lower mean distances between the landmarks. However, in 3 patients, the reverse of this was actually seen. More detailed results were published online in a supplementary figure, which can be seen here on the right. The heat maps of intersurface distances for the medial femoral trochlear lunate articulation was relatively uniform, whereas the capitate lunate heat map showed a central congruity, but increased intersurface distances peripherally. This is demonstrated well here in subject 8, with red colorations seen on the heat map peripherally. Mean cartilage thickness for the medial femoral trochlear, capitate, and lunate were measured, but there was no further comments or analysis of this made. The authors then discuss some variations in anatomy and give some subject-specific examples, such as subject 6, who had an unusually prominent ridge along the medial femoral trochlear, which correlated with an area of incongruity on the heat maps. The paper concludes that the medial femoral trochlear is more likely to provide a more anatomical replacement of the proximal lunate than performing a proximal row carpectomy. Exceptions to this do exist as a result of variations in anatomy, with the capitate being more favorable in some cases. Whilst anatomic variations can be assessed for, it would be difficult to fully appreciate this without the advanced 3D calculations, the availability of which is limited. However, the use of 3D morphometric analysis may provide useful supplementary information and help procedure selection for individual cases. In summary, this paper presents a novel technique of comparing 3D articular surface anatomy and highlights that variations in anatomy can affect articular surface congruity. Unfortunately, the design of the study has not allowed for any clinical correlation, and the small numbers involved in the study is also a significant limitation. As a result, it's underpowered for any subgroup analysis, such as by lunate type. The analysis of the articulation also relies on a virtual bony alignment, which may be different to the anatomical alignment seen in reality. The authors do, however, accept and note these limitations in their discussion. They also make the suggestion of further 3D analysis of post-operative patients, correlating both radiological and clinical outcomes, which would certainly be very interesting. Thank you.
Thank you very much, Adam, for that. If you could unshare your screen, thank you. I'd like to go straight to Mitch, Dr. Peth, congratulate you on your paper. Quite an original piece of work. Where and how did you get this idea to look into this?
Thank you so much. I appreciate the presentation, especially from Adam. That was exceptionally well put. The idea for this paper came from publishing some of the outcomes data from this procedure that we've done, and that was some work that I did with Dr. Higgins, who's a wonderful mentor of mine. In writing those papers, the papers always begin with an explanation of why one might ever consider a complex reconstructive method like a medial femoral trochlea free flap. And part of that argument usually begins with the idea that this free flap, this trochlear flap, may be a better replacement for the lunate than an alternative. And the alternative we looked at this time was a proximal row carpectomy. And so that asserts the possibility that MFT is a better shape match for the lunate than the proximal capitate. And it turns out that in reviewing that evidence, that the evidence supporting that supposition was relatively weak. It was conducted in 2 dimensions. It was done on CT scan data, which doesn't look at cartilage. And we thought that as we wrestle with the indications and how to incorporate this new idea into my own practice, I thought that understanding at a higher level the degree to which the MFT may be better or worse than the capitate in terms of matching the lunate in shape was worth knowing.
Thank you. Thank you. Can I go to Ian? Ian, just your thoughts on the paper, and is this something that are you convinced it's something you would consider?
I think it's fascinating. I'm not an expert on the methodology, but I've no doubt that it's accurate. I think what might be helpful, and I think for a lot of people, certainly myself, is perhaps a brief description from Mitchell how the operation is undertaken. What actually do you do?
Dr. Cho, could you clarify? Are you talking the surgical operation or the operation of doing this? Okay.
Surgical operation.
Of course. I feel funny describing this operation in the same chat as Dr. Berger, but I'll do my best. So when I do this operation, I begin by opening the wrist. And the first step is basically exposure of the proximal carpal row and inspection of the articular surfaces to make sure that there's a suitable radius cartilage in order to proceed. In my opinion, the most critical part of the operation is the resection of the proximal lunate, which is usually done in my hands with a small saw. And that is a resection that is just about coplanar with the surface of the radius, leaving the distal half of the lunate in its articulation with the capitate. Now, in many cases, there's a split between the dorsal and volar horns of the lunate, and the next step is to actually repair that split with the suture anchor. Has been described by Dr. Higgins and Dr. Gillis. And once that's achieved, and I know that I have a suitable recipient site with a reconstructed distal lunate, then there's an exposure of the knee, a reflection of the vastus medialis and the descending geniculate vessels, and then the transverse branch as it crawls up on top of the condyle towards the trochlea is dissected. The pedicle is actually divided proximally, and then 3 osteotomies are used to harvest this sort of medial femoral trochlea segment. There's a brief trimming of a couple of sides to make it fit the defect, for instance, to match the width between the tracheatum and the scaphoid, and then little bits of trimming to have it kind of click in there to replace the proximal lunate with the convex cartilage, of course, facing the radius. And then the microsurgery is done in the anatomic snuff box.
The only issue I would take, that's actually reconstructive surgery, isn't it? You're actually reconstructing the lunate. It's not, that's an academic point, but it's not really a salvage operation, is it really? You're sort of rebuilding the lunate, really. So is that correct? Hopefully restoring it to what it should be. rather than sort of fusing or excising it or whatever. You know, that's what I would call a salvage procedure, really. So I don't know whether I would compare it to proximal row carpectomy. That's all, really. I think it's more than that, isn't it? It's much more. Is that fair, do you think?
I think that's absolutely fair, and it's a wonderful point. And it is a reconstructive procedure, and some other potential, and I emphasize potential benefits of this procedure, if you'd like to hear them, are just that you maintain a more normal carpal anatomy with preservation of the carpal row, of the proximal carpal row, which may be advantageous, though that remains unproven. The reason for comparison to proximal row carpectomy really is a clinical situation where, as the physician recommending surgery, you have several options, but among them, and in my practice, often considering a reconstruction with a vascularized osteochondral flap versus a proximal row carpectomy. And so that's where the comparison came, is from the clinical situation that I found myself in.
Professor Berger, can I bring you in terms of your thoughts on first of all the paper and also the technique that Dr. Pett describes in your personal experience?
Thank you for the presentation. I appreciate it and I like it. And so from my point of view, it's hard for me to compare two techniques like the proximal row carpectomy and the medial femoral trochlear graft, which I studied together with Jim Higgins. It was in the year 2008. Jim was there on his Godina traveling fellowship, and he was close to Carinthia, my hometown in Slovakia. And we did my second case. I said, Jim, hi, I think I have quite a good procedure. Please come and see. Let's do it. But it was a scaphoid. But we proceeded to lunate some years later. Anyway, from my point of view, I've done my last proximal row carpectomy. I think it's 15 years ago. So I do not do that in any case. So for me, the only way for lunate reconstruction and Kienböck's reconstruction is the medial, and I have to add the lateral femoral condyle trochlear graft. So I take the graft from medial and from the lateral side. And of course, in the presentation, you focus on the medial side of the trochlea. From my point of view, and in my practice, sometimes the lateral condyle is better. But of course, I still use the medial condyle, the medial trochlear graft for lunate reconstruction. Speaking about the approach, in 15%, the approach is from the dorsal, and around 15 other cases, I come from the palmar side. First of all, I make CT scan, and in the sagittal plane, I decide which part of the lunate is better. In nearly all cases, the lunate is broken in the coronal plane, so always have the fracture. So most of my cases are stage 3 or stage 4, sometimes 4. I have to add in coming to stage 4. In the presentation, you beautifully has shown that the cartilage is around 5 times thicker on the trochlea than it's on the lunate. So it's much thicker, and of course, it's more resistant against maybe not best situation on the lunate fossa of the radius. So I resect the dead part of the bone. In contrast to Jim takes a suture anchor, I take a screw. I try to fix the broken part, the distal corn of the lunate. I fix it with K-wires, 0.8 or 1.0. I fix it and sometimes add a screw. And after fixation, I resect the dead proximal portion of the lunate. And then I bring in the graft from dorsal or from palmar. And for me, it's very important to add at this part, when I completed the resection and I made the plane which the graft has to meet, so that means the distal portion of the lunate, I bring in a template. So what I do, I take a piece of bone wax, and I bring this piece of bone wax in a thin silicone sheet. This silicone sheet, you can take a glove, you can take the finger of a glove, put some fluid, some irrigation in, and then the bone wax. and then I make a template. I made a template in slight overcorrection. So I put tension on the finger, put in the template, put out the template. I take a pin and I mark the plane of the cartilage. You only have one plane with the cartilage. The other planes, they have no cartilage. And then I open the knee joint and I bring the graft right to the medial or lateral part of the upper portion of the knee. And then I cut it out, and I cut out the graft exact in the dimension and at the plane which the graft showing me. So when I hold the graft, I move the graft and I look at the plane and I look which the best fit of the plane is. And if I make that, I mark it and then I make the incision, put out the graft, put it in, fix it with 2 screws, and hook up the vessels, of course, 1 arteria, 2 veins, whenever I can. So that's I have to say I have done many procedures in lunate reconstruction, but now since around 10 years, that's the only way I reconstruct the lunate. I do not put any inlay graft. I use the medial femur chondral osteochondral graft without cartilage, and I used, of course, the iliac, and I used other 4-5 and local grafts and vascularized, non-vascularized. But since then, I only take that. And if the lunate is completely damaged, if I cannot keep the distal part of the lunate, I make a fusion from the graft to the capitate. So I make a mid-carpal fusion from the capitate to the new lunate. So I completely reconstruct the lunate and fix the graft to the capitate.
Fascinating. Thank you, Professor Berger. I want to go to Michelle next, please. Michelle, I just want your thoughts as the handling editor for this particular paper, quite a unique, original piece of work. Just your thought processes and the actual, any issues you had with the paper itself, the methodology, etc.
Well, I think from the beginning, I went for accepting this paper because I think it's an interesting study. As we have heard, it has been used, the procedure has been used clinically by several people, but it has not been proven really superior to other procedures in terms of durability, in terms of degeneration of the joints, etc. So it's a basic study, but it's an important study. People say it is important that the articular surfaces match, but then of course you need to investigate, is that true that they match? After that, you can investigate, is it true that it is important? So this is the first step in that chain of investigations. And I think it's well done. Now we have been discussing a lot right now about the technical aspects of the procedure. This is not the topic of the paper. The paper is purely basic examination of the joint surfaces. The conclusion shortly is that the medial femoral trochlea matches better than the capitate in the majority of cases, but not in all. Something like 30%, the reverse was true. We need to remember that. I was just, that's mainly my thoughts. When I asked for several revisions of the paper, this is almost always necessary, because authors, they have a lot to tell you. They have a message they want to spread through the world, and they often use many words to do that. So in general, the papers are too long. Papers have to be concise if you want the readers to keep focused and to read your paper. If it's too long, too complicated, you lose many readers. That's not the purpose of the journal. The purpose of the authors is to spread their message. The purpose of the journal is to make this message accessible to as many readers as possible.
Okay. Thank you. I want to bring in Carrie Allen, who's a co-author on this paper. Carrie, if you could just briefly explain to our audience your role in the paper and some of the technical aspects of what you did. And I'm also interested in terms of the time it takes to do what you did and the costs involved in that to see whether this is something that is reproducible. Thank you.
Yes, hi. So my role in the paper was that Mitch came to me and explained the procedure and the rationale for the procedure and this idea that people had that it would better replicate the original anatomy of the lunate. And he wanted to test that. And so he said, you know, how do we actually measure that anatomy to see if that surface matches? And I'm a comparative anatomist and a three-dimensional geometric morphometrician by training. So this is something that, you know, is a pretty common computational problem that I work with in my research. So yeah, we sat down together. We you know, did virtual surgeries together so that we could try to figure out the best way to minimize our inter-observer error, make sure everything is as replicable as possible, and you know, doing this measurement of distances between the comparative joints and representing that visually as a heat map, we thought would be the most approachable way to the readership to be able to really convey the differences between the two analogous surfaces. So that was my role, was the math. And in terms of the time that it took, it is, you know, and I think Mitch will say this isn't at this point something that we would say is what you should do with every patient, although he could elaborate on that. For this, you know, we had to collect the MRIs. We had to do the three-dimensional reconstructions based off those MRIs of both the cartilage surface and the bony surface. And so this was something that myself and my postdoc worked on. It took us, you know, we could get down to a few hours per individual to do the surface reconstructions. Once we identified the regions of interest and were able to do, you know, a nice homogenized procedure for the virtual reconstruction, that itself would take us, I don't know, what was you say, Mitch, a couple hours as well for a specimen. And then getting the actual math and that pretty picture of the heat map is very fast, is just a few minutes there. But so yeah, so for each individual, this was several hours of time and effort, plus the cost of the actual imaging.
Quite costly, I imagine. Yes? No, you're not saying, okay. All right.
It's costly in terms of time.
Yes.
Yes.
Costly in terms of
time cost. Can I ask because before we move on, I want to come back to both yourself, Dr. Pett, and Prof. Berger. You know, there is obviously more morbidity involved in taking a graft from the knee. And Michelle has said that the results of this technique are not proven to be better than other techniques. And Ian may have comment upon that as well. So with the context of that, is the actual procedure viable in terms of the time it takes? I'm sure it's an expensive procedure to do in terms of theatre time and equipment and morbidity to the knee. Do you think it's justifiable? And I'm happy for Ian and to also come in on this. But if I could ask Michelle, Mitch, and then Heinz.
Okay, thank you for the question. I think it's a very pertinent question. And I think has been mentioned a couple of times. It was certainly not the object of this paper to answer that question, but I'm happy to make a comment on it. In terms of the you know, how doable is this procedure, I think the truth is that for some, you know, there's a learning curve and you have to learn how to do it and you have to be interested and capable in microsurgery. But in reality, I find this to be much quicker than most of my, many other free flaps. The harvest is straightforward. The vessels are always, I shouldn't say always, they're 87, 80, 90% of the time in the same spot. And if they're not, they're in an accessible alternate spot coming out from the popliteal fossa. There's no perforators. It's all right there. And once you're comfortable with the osteotomies, the process of osteotomy takes all of 6 or 7 minutes. It's also amenable, if you're into this, to two-site surgery because you're working on a knee and a wrist. And so the truth is that this type of operation is something that you can do in several hours. It is not a whole day surgery and usually done for lunch. I'm sure that Dr. Berger is done before breakfast, but I am done before lunch. So I do believe that it's doable, it's feasible. And then the question of morbidity is a very, very good one. And it is something that's the part that I wrestle with as I think about how I want to treat my own patients and talk to them mostly about that. The available data, which has been published in Journal of Hand Surgery American volume over in 2 papers, is favorable. It would indicate that there's minimal morbidity, but non-zero morbidity. And I think that especially in the realms of twisting and sports activities, some patients do report that they notice it at intermediate follow-up. And often we've seen that people tend to do better and better over the years of recovery. Long-term data cannot and does not exist yet, and that will be of great interest, I'm sure, in the future.
Prof. Berger, can I ask you, because you've been doing this for many years, your briefly, if you could.
Yeah. Thank you. That's a very good question, and so I have to say there is a multi-center study right in press, and we will publish this within the next month around the donor side morbidity. So I'm doing this procedure since the year 2006, and I have done around 380 cases. So I took 380 grafts from the knee, from the inner or outside of the knee. So I've done that in over 40 different hospitals. So it's really hard. You will understand, really hard to bring all that patient back. But you can be sure these guys in these hospitals, they would send me the patient back and would tell me, "Hey, doctor, you've done this graft from the knee and the knee is now done. Please take care for the patient." So it would stop me immediately if there would be a high donor side morbidity. I had one infection with no major destruction of the knee. We had one revision, and we had the possibilities to scope 3 or 4 patients. They had some other menisc lesion on the knee. So by the way, we put the scope up to the knee, of course, up to the donor region, and we could look at the region, and we found some cartilage. Of course, it's some regenerative cartilage. It's not an hyaline cartilage, but it's good. And I completely agree that the patients are complaining some weeks and around 3 months about pain, but this pain gets better and better and better. And so most of them, nearly all, are pain-free in around 4 months after the surgery. And they get better by the time until, so nearly all of the patients asked me, if I asked them, would you go again into this procedure? They say yes. So, but I have to say, the study is right in press, and it's a multi-center study, and will be an honor for me to present this study. The chief author is Max Neuwirth. The name of the author is Max Neuwirth, and he made this study including 7 Tesla MRI, and really, I think it's a good study.
Fantastic. Thank you for sharing that. We look forward to that paper. I'd like to thank everybody for this part of the meeting tonight. Well done to Adam, and thank you for everyone's contributions. We've got a little treat for you now, a little video that we're going to play. We'd like you to sit back and enjoy the video. And after the video, which is only for a few seconds, we will take the next paper. So enjoy. Fantastic. We're all very excited here at the BSSH in organising next year's International Federation meeting. Apologies. The meeting next year. And we all hope that you will be joining us, and we hope that it's going to be a face-to-face meeting. We're quite sure it will be. Please join us for that. I'd like to invite Antonia now to present the second paper.
Thanks very much, Saf. Good evening, everybody. I've got the pleasure of presenting tonight's second paper, which was published in June 21 following revisions. Dr. Saeed and Professor Adasuki and colleagues from Egypt published their work on radial shortening, bone grafting and vascular pedicle implantation versus radial shortening alone in Kienböck disease. So the authors start by noting that revascularization procedures are treatment options in stage 2 to 3A Kienböck disease if the ulnar variance is neutral or positive. For ulnar negative variants, radial shortening is recommended instead. They hypothesized that for ulnar negative patients, combining radial shortening with revascularization would provide a better biomechanical environment, and it would provide higher rates of revascularization with associated better pain relief and better functional outcomes than radial shortening alone. The paper is a prospective study with appropriate ethical approval and patient consent described, and patients were pseudo-randomized based on case note number using odd versus even numbers, with all surgeries performed by the same operating surgeon. As such, it's a non-randomized control trial and can be described as level 2B evidence. So the cohort demographics were well described and included 27 risks in 27 patients. 10 of the patients were Lichtman stage 2 and 17 were Lichtman stage 3A. Patients in both operative groups were reasonably well matched for age and sex, and the age and sex distribution reflects the relative epidemiological incidence of Kienböck, with its preponderance for males aged 20 to 40 or so. Inclusion criteria were well defined as patients operated within a 4-year period with stage 2 to 3A Kienböck disease and negative ulnar variants. And likewise, exclusion criteria were well defined, including patients with lunate fractures or previous surgical treatment. Patients were followed up for at least 3 years, with a mean average follow-up of 4.5 years. Of note, though, 30 patients were included in this period, but 3 were lost to follow-up, which left 27 patients included in the study overall. The surgical technique I'm presenting in this slide, the radiographs are from the publication, and I've added some supplementary illustrations based on the descriptions that were given in the text. So in all cases, surgery was performed under general anaesthesia with a tourniquet and IV antibiotic cover given 1 hour preoperatively. For the radial shortening, a Vola-Henry approach was used to the distal radius. The shortening osteotomy was performed 3 centimetres proximal to the wrist joint with an oscillating saw and fixed with a small T-plate, as you can see on the radiographs. For the vascular pedicle implantation, the lunate was approached dorsally with a longitudinal incision just radial to Lissus tubercle. The extensor retinaculum was cut, and the 4th or 5th extensor intercompartmental artery was dissected to its origin distally from the dorsal carpal arch. The lunate was exposed via a longitudinal incision through the wrist capsule, and a burr was used to open a small window in the non-articulating dorsal portion. Any necrotic bone was excised, and then cancellous bone graft from the distal radius was packed into this cavity. The intercompartmental artery was then fixed into this via a drill hole, which created a channel, and fixed with 8 sutures and microinstruments. Then 2 KYs were used to fix the scaphoid to the capitate in order to unload the lunate and avoid graft collapse. For both groups, there was a drain that was used and removed day 1 to 2 postoperatively, and the wrist was held in a neutral position in a volar below elbow splint. The post-op pathway for each group is shown in the table. The main difference between the 2 groups is that radial shortening only patients were removed from splintage and commenced full mobilisation 2 weeks post-op, whilst the vascular pedicle implantation group could only commence that full mobilisation when the wires were removed at 8 weeks post-op. Clinical assessment was performed by 2 hand surgeons who weren't involved in the study and therefore were relatively blinded. Data was collected at each clinical visit, and that included range of movement, pain scores, a visual analog scale, at rest and on exertion, grip strength, and functional assessment with quick dash. Patients were also monitored for inflammation and infection both clinically and with biochemical markers such as CRP. and wrist radiographs were taken to measure ulnar variants, check for any degenerative changes, and also assess osteotomy healing. Once the osteotomy had healed, the plate was removed and an MRI was performed to assess for revascularization of the lunate. And in any cases with incomplete revascularization, a repeat MRI was performed after a further 6-month interval. Those MRI scans were then directly compared with pre-op scans, and revascularization was graded according to set criteria, which was grade 0 if there was no revascularization, grade 1 for partial revascularization, grade 2 for incomplete revascularization, and grade 3 for complete revascularization. Patients then had 6 monthly follow-up thereafter for the total period. The results were presented clearly with pre and post-operative data given. Both groups demonstrated a significant improvement in all parameters between the pre and post-op assessment, but for clarity, I've only included the post-operative results on this slide to allow comparison of the radial shortening only group versus the vascular pedicle group. Active range of movement improved in both groups to over 80% post-operatively. Pain scores at rest improved in both groups from a 3 preoperatively to 0 postoperatively, and on exertion there was a similar improvement, although interestingly the VPI group experienced an additional degree of pain relief compared to the radial shortening only group. There's a similar pattern seen with grip strength, which improved in both groups, but with a greater improvement in the VPI group, and likewise functional assessment, there was a better improvement in quick dash. Whilst the quick dash is statistically significant, the authors do note in their discussion that in reality it's only a difference in score of 4, which is below the minimal important clinical difference, which is normally 10 to 15, that's generally accepted. The starkest difference, however, is in the radiological outcomes, with far more patients in the VPI group going on to have a degree of revascularization that was grade 2 or grade 3 compared to the radial shortening alone group. In terms of complications, the authors report that no patient experienced a worsening of their pathology or symptoms. There were 3 complications in the vascular pedicle implantation group, which were 2 superficial wound infections that settled with antibiotics and dressings, and 1 case of wire migration into the wrist joint, which is described as having no subsequent short or long-term effects. So in summary, this was a prospective pseudo-randomized trial comparing radial shortening alone with radial shortening plus vascular pedicle implantation performed by a single surgeon. The authors presented a clear hypothesis and surgical technique, and they do demonstrate improvements in revascularization for radial shortening plus VPI over radial shortening alone, with additional marginal benefits in pain scores on exertion, in grip strength, and in quick dash functional assessment. However, they do recognise that the vascular pedicle implantation involves 3 surgical elements, so the decompression, the bone grafting, and the implantation itself, that could each contribute to improved revascularization, and this study doesn't distinguish which of these elements contributes to the improvements seen over radial shortening alone. So I'll now hand over to the panel for discussion, together with my question to them, which would be, how will this study influence your practice? Thanks very much.
Thank you. Well done, Antonio. Thank you for that. I'd like to go to our author, actually, to start with, Professor Adesukyi. Welcome again from Egypt. Congratulations on your paper. I'm going to ask you that question straight away, actually. Are you still, based on your paper, are you doing vascularization?
Yes. After the results of this paper, can you hear me?
Yes. Very well.
Okay. After the results of our study, I always do revascularization plus unloading procedure, whether it is radial shortening or capitate shortening. I almost always do revascularization stage 2 and 3A.
Okay. If I just push you a little bit on that, so the outcomes you've said in terms of clinical difference to patients, there is no difference. So are you not causing more morbidity to the patient by doing what you're doing?
Although there is no significant clinical difference, however, we have a solid revascularization in the revascularization group than the radial shortening only group. So I think in the longer term follow-up, after maybe 10 years or more, I think there will be some difference. And also all the published literature of revascularization said that in most cases, the pathology of the disease is stopped when we do revascularization. However, when we do only radial shortening, there is no stopping of the pathology. The clinical outcome is good, but however, there is no stopping of the pathology. The pathology goes on.
Okay, I'm going to go straight to Ian actually now. Ian, you've obviously studied this condition for your entire career, and you did maintain a Kienböck database out in the Northwest, I remember. Should we vascularize? Do you vascularize still?
Yes, yeah, I think we should. I think the author should be congratulated, actually. To have I mean, Kienböck is such an uncommon condition, if not rare condition. To have a prospective comparative study is incredible, really. I mean, and again, hats off to you. I mean, if you look at the whole condition, I think you could, there are what, less than 5 comparative studies? I mean, it's not hip and knee replacement, this. It's they're mostly all case or cohort studies, aren't they? So I think to have a study like this is excellent. I mean, in 2000, we published a comparative study comparing conservative treatment, which is still a viable option. You know, if patients aren't suffering too much, then they don't need an operation, as against radial shortening, and showed advantages of radial shortening. And I think this takes it one stage further, really. And yes, I think if you're going to do surgery, and patient symptoms will decide that, and the lunate is reconstructable, and I think this is the technique of choice, and I would use a vascular graft, yes.
How do you do your vascular graft?
I would probably, well, I would get somebody else to do it, but I think I have one question. I'm an orthopedic surgeon. I used to use the local grafts. This is quite a funny story. One of our plastic surgeons came in one day, a plastic hand surgeon, and said to me, this must be a graft designed by an orthopedic surgeon, which I didn't quite appreciate at the time. I have one question. Why did you use K-wires, temporary K-wires? Because you're already addressing the biomechanical sort of issues in the wrist, weren't you, by doing a radial shortening? So why do additional K-wires, which may cause, I think in one case did cause a complication?
You know, in our technique, we remove the necrotic bone from the lunate, and then we pack a cancellous graft inside the lunate. So I was afraid that if there is some load, it may collapse. So I just put the K-wires to protect the cancellous bone until some consolidation occurs.
Yeah. Okay. But I think it's a very good paper. I think, again, if I was reviewing this, I think I understand the numbers are small, but you do have statistical significance. Goodness, in Kienböck, that's heaven, isn't it? We all want that, And I think I would have put it the other way around, that you have got clinical improvement, but you acknowledge the numbers are small, rather than the other way around. That would be my, I think you've undersold it a little bit.
Okay, thank you. Yeah.
Thank you.
Yeah, so I have a question from the audience. In fact, it's Sue Folilov, our president. She's asking, she's an orthopedic surgeon too, like myself and Ian. Why do you need microvascular techniques to implant the vessel into the lunate?
I don't need. I just use.
You don't need. Yeah. What do you do?
I just use the microforceps to introduce the vessels inside the hole,
okay,
to avoid injury of the vessel. I do not need the microsurgery.
Okay. Okay. I'm gonna ask Professor Berger to come in. I think I know the answer to the question, or your answer to the question. You will be advocating vascularization, but is this something you would do at early stages of Kienböck?
As I mentioned before, only for Kienböck disease, my only procedure is the medial or lateral femoral trochlea graft. So I make no radial shortening. I have many cases which come to me after radial shortening osteotomies. And as mentioned before, I resect the bone and the cartilage. So what I, in my practice, what I nearly always find is damaged cartilage. So for me, in practice, removing that bone and leaving bad cartilage structures in place makes no sense. So I always remove the cartilage and the bone and the dead bone formation. So in my practice, nearly always, if I find in my cases that bone and bad cartilage situation.
Yeah, sorry.
Yeah.
That implies a late stage of Kienböck.
Yeah.
What do you do with patients who are in severe pain at early stages of Kienböck's? Would you be taking off the cartilage then?
Good question. I make a scope and look at the cartilage, and if the cartilage is bad, again replace cartilage and the dead bone or the borderline of the bone. Anyway, to find a good match bone to bone. Anyway, most of my cases, and I've done around 106 cases, 106 with this technique, and around 60 of them with a medial femoral trochlear graft and 45 with the lateral femoral trochlear graft. The pedicle of the lateral graft is too short for a dorsal approach. So if I go for a dorsal approach, I take the medial trochlear graft. If I palmar approach, then maybe for me, the lateral condyle is a little bit quicker to harvest, and I need just a short pedicle. Anyway, I like super microsurgery, so I take a very, very short, thin pedicle to make the donor side mobility as less as I can. But I have just a question. Did you compare the outcome of smokers to non-smokers? Because in my practice, there is a huge difference in the outcome of smokers. They do much more worse. So non-smokers are doing so much better. And I tell to all the patients, you don't have to smoke during the healing period, which means 3 months, 3 to 4 months. Maybe I didn't found it in the study, but I think for revascularization procedures, smoking is a huge thing, a big thing.
No,
Yeah.
no, we did not compare that.
Okay. And can I'm going to come back at you, Professor Berger. If you do a scope and the cartilage is fine and the patient's in pain, you have early stage Kienböck's, are you not going to offload that lunate? Do you believe in offloading, or do you not believe in it?
Yes, I would do that. Yeah, I would do that, but I have no case. To be honest, I don't have one case. I only have one case. It was a very, very obese young lady, a very, very obese. And in this case, I made a radial shortening osteotomy, and it was working. Okay,
thank you. Michelle, I'm going to come to you now. High praise from Ian regarding the paper. Did you feel the same way? Did the paper need any revisions, or did you have any skepticism or any concerns?
Well, I think also the final product is very good, and I think it's a good and an important study. And I thought it's from the beginning. That's why I accepted it. It has always been a question for me personally, but I know also for other people. We make radial shortening, but should we do something more than that while we are doing this radial shortening, or should we just leave it as it is? And I think this paper gives us a part of the answer. Yes, it is worth doing something more. You gain revascularization. Which component exactly gives you this higher revascularization? We don't know. The paper doesn't give the answer. Is it the bone graft? Is it the artery? Or is it merely the stabilization with K-wires? And one more question is, I didn't ask the authors that, I didn't think of it, but I think of it now. Did you do a resection of the posterior interosseous nerve during the revascularization procedure, or did you not?
No, I did not.
You did not. Okay, that's fine. Yeah, that would be one more confusing factor, but this is okay. Another question is, why did you not randomize? Why did you do this selection by taking patients on odd dates and on even dates for the one or the other procedure?
At the time, we think this is a very simple randomization method, and we don't think it would be a bad choice.
You are sure you did not?
I wish I did.
Yeah, you are sure you did not introduce a bias of any kind by doing it this way? No.
At the time, I didn't think of that.
No, okay, yeah, it would have been nice, but anyway, it ended up being a good study, I think. And I would like to add also, to the question of the small numbers, the remark that Ian made, actually you made power analysis also, which accepted these numbers, in fact, as being adequate. So that's good. It's very important, especially in papers where you have negative results, no differences.
The Kienböck disease is small.
I think it's very important that if you write a paper and you have negative results, no differences, that you have a power analysis. It's very important. We mostly require that as editors.
Okay, thank you. I'm just checking. I think we have some more questions. Okay, a question from an anonymous attendee. Can someone explain to me? I'm gonna try and read this in a very in the mood that I think that the question's been asked. Can someone explain to me how you think it's possible to put an artery into a bone and think it won't clot or thrombose? I mean, I don't think any plastic surgeon is satisfied with putting an artery to a flap without an established venous drainage. Who wants to answer that?
Actually, Dr. Hori in 2007 performed a experimental study on canine, and he put a vessel inside the bone, and then the results of the rows are rising and revascularization of the bone. So this study was based on a pre-experimental study done by Professor Hori. So actually, it will surprise the whole.
So the panel's in agreement. Do you want to say anything more on that, Michelle? You're going to quote the same.
I would have quoted the same paper by a study by Hori, but I would say the explanation is that there is a kind of sprouting, a neovascularization of the vessel that you put inside the bone there.
Okay. Heinz wants to say something.
Yes, there's a quite old animal study done by my friend Alan Bishop from the Mayo Clinic, and he made an animal study on dogs, and they put in a AV bundle, so they didn't put an arteria. And I think in practice, if you take this dorsal articular network, you always have some committant veins. There's not only an artery. There's an artery and some veins, and of course there are connections between those. So there would be still a perfusion. Of course, if you would take a clean artery, of course that would thrombose. If you would take a clean vein, of course that would thrombose. But if you put in an AV bundle, and I think maybe the nomenclature is it's wrong. Maybe you shouldn't say artery. You would say an AV bundle, and I think this AV bundle, it's keeping alive. And what this study was shown, that the reperfusion of the dead bone came by the veins, not the arteria, the venules, the very, very small veins opened and they reperfused the bone. So I say maybe the real findings, what's behind them, they're not coming from the artery, they're coming from small veins. But anyway, I think it works, and it has been proven by studies.
Okay.
Yes, we name it vascular pedicle, not arterial pedicle. We actually harvest the both vein and artery. Vascular pedicle, not artery.
Yeah.
Thank you. I've got one final question. I think it's a question, also, I guess, a comment, and then I'm going to take you all to the case that I presented at the start of the meeting to be able to round off the evening. The question comment is from Rob Poulter. I'm going to address this to Ian really to answer. Should all Kienböck's cases be put on the UK hand registry to get sufficient numbers to eventually to be able to answer some of the many questions?
Yeah, I think so, yes. I think some sort of registry. If you're ever going to get clinical outcomes, you're going to have numbers. And if each surgeon does 2 or 3, one a year, we never get, there's got to be some sort of register. And that's not to say the surgeons can't do them, but some sort of grouping, or multi-center, so we can do multi-center studies, if you like. Yes, I agree with that. I think it would increase the numbers and make more reliable outcomes, yes.
Okay, there's a little plug for our UK hand registry to all attendees tonight. Okay, I'm going to go back to my patient, and I'm hopefully going to get lots of advice now as to what is the right thing to do, following all the knowledge that we've gleaned tonight. Oh, so that's the wrong. I'm not getting any better at this. So we're going to share. Try again. No. Try one more time. I don't. My apologies. Just give me 1 second. Okay, we're back on the case discussion. The case I had was a 35-year-old lady with 7 months of dorsocentral pain in the wrist, no trauma, no improvement with conservative measures. That was her X-ray. That was her ulnar variance. The CT revealed the lunate to be in the situation you can see, particularly in the middle image, and the MRI scan you can see there. So I'm just opening this out now. Ian, your preference for this?
Yeah, well, I think my decision-making process is, firstly, if the patient's coping and doesn't have any symptoms, then I think, or minimal symptoms, you can treat this Kienböck conservatively. I'm not sure there's great evidence that doing anything prevents anything long-term. That to do an operation to prevent things is not in my makeup, really. I can't guarantee that. I think if you're going to do something, then you rely on imaging. I think this is obviously, I don't think the scale is flat, so it's a 3A probably. Then I would go for some sort of reconstructive procedure, which it would be the form of some sort of radial shortening and a vascular graft.
Okay. And any preferences?
Well, I think we use a Zeidenberg, probably. Is it a 3-4 graft with actually it's a vascular graft with some bone attached to it, which you can swing into again, described to me by a plastic surgeon as a graft described by an orthopedic surgeon. But I mean, I don't know what that meant, but that's what we would probably use, and then decompress the lunate as well. And I think the results of that show, from MRI scans, show good results, actually, revascularization. And hopefully the lunate will heal in the shape that it is now. That's what you really want. I mean, I think the big question is when you move, people who try to reconstruct the lunate, when is it unreconstructable? Is it never? I mean, some of them are, some of the 3Bs are hopelessly squashed and fractured. Even if they heal, what sort of position or shape do they heal up as? Is it obviously significant deformity? Is that of any long-term benefit to the patient, that they have a healed lunate that's completely out of shape, completely deformed? Or do you move? And I guess the question is, when do you move from reconstructive to salvage? For me, that's a question that's not yet been answered. Thank you.
Thanks, Ian. Michelle, would you like to make comment upon this?
Yes, I would like to. I am a little concerned when I look at these imaging. I'm concerned about the midcarpal joint, the joint between the capitate and the lunate. It seems arthritic for me, but it's possibly not the case. I would go ahead with an arthroscopy first to assess the cartilage in these cases, and then I would act accordingly.
Okay, and if you felt that the cartilage was okay,
if I found the cartilage was okay,
the midcarpal cartilage was okay.
Yeah. I would reconstruct the lunate probably and make a radial shortening at the same time. Reconstruct the lunate by putting in a screw to fix the fracture and make a radial shortening.
Okay, Professor Adasuki, your preference?
I think In this case, I will do lunate excision and scaphocapitate fusion.
In this case, you do a lunate excision and scaphocapitate fusion. Okay.
Yeah, yeah.
And what's your rationale for that? You think the lunate's gone completely?
Yeah, and so.
Okay, thank you. Is Mitch still with us?
Oh, yes.
Mitch, go for it.
I, in short, would do the operation I described earlier, which is resection of the proximal lunate, repair of the coronal split, and reconstruction with a medial femoral trochlea osteochondral 3 flap.
Okay, and you wouldn't touch the radius?
No.
No need. Okay, and
I would stop short of no need, but I wouldn't touch it. That's a lot of surgery in one day.
Okay, thank you. And I can imagine what Professor Berg is going to say, but please do enlighten us.
I would come from a dorsal approach. I would fix the distal part of the lunate with a 1.2 millimeter titanium screw. Then I resect the damaged part of the lunate, which would include most of the dorsal fractured part with the cartilage, go a little bit primary, and then go to a medial femoral trochlear graft and hook it up with a second incision to the radial artery.
Okay, fantastic. Well, I'll show you what I did. I did an open approach from the back. I fixed the lunate with a compression screw. I did a 4 and 5 vascular bone graft with bone, with the pedicle, and implanted that in the dorsal aspect of the lunate. I did a radial shortening and did a neurectomy. So that's the post-operative image. And this is the X-ray at 7 years. Any comments really on that? I mean, she has done okay in terms of pain, and she's coped, and that's the morphology of the lunate right now. Well, 7 years on.
I would like to make a comment, if I may.
Yes, of course.
Yeah, I think again here we have to look at the mid-carpal joint. It doesn't look too well, and
Yeah.
I am surprised that our colleagues, Mr. Pettenberger, they advocate replacement of the proximal part of the lunate. This part seems nice. Also in the preoperative imaging, the cartilage seems okay. So why replace it? I understand the replacement with the medial femoral trochlea is also a revascularization procedure. That's true, but you have other possibilities to do that.
Okay.
See a CT scans off, wouldn't it? Or an MRI scan at this stage, or CT scan.
Yeah, sorry, I haven't got it. No, I haven't got that. But are you? I mean, you would have gone down the same route, Ian, in terms of vascularized bone graft. Yeah.
I mean, I take the point about articular cartilage damage. It's something that's never really, until Greg Baines, I suppose, brought it to everybody's attention, that most people have ignored the cartilage really for a long time.
Yeah.
And maybe that was a mistake. Maybe we should be addressing that more now, or considering it more in our decision making than we ever did. But I mean, I don't look at those films. I don't see any significant deterioration, I have to say. But maybe a CT scan would show more.
Yeah. Yeah. Okay. Could I ask Heinz and Mitch to just address Michelle's question about the mid-carpal joint and your technique? Yeah.
Let's start just from my point of view. I have many cases which have problems mid-carpal on the cartilage, but they are not in clinic. They don't complain about pain. And I think the joint surface between capitate and the distal part of the lunate, it's only a part of the mid-carpal joint. So I do not think that it's that important than the proximal part of the lunate. I think the proximal part of the lunate meeting the radius is much more important than the distal part. So in my practice, I have many patients with showing osteoarthritis of between the distal lunate and the capitate, but they are not complaining. They're not complaining about pain. So I do not care that much about the situation mid-carpal.
Okay.
I have a slightly different perspective. I certainly have less experience, and I've been less aggressive in my indications. For me, patients who have no coronal split generally don't have a problem with metacarpal arthritis, and I don't really worry about it unless there's a reason to on the X-ray. If they do have a coronal split, I look at it carefully, and if there's evidence of substantial metacarpal arthritis, I generally don't proceed. And then finally, to the extent of like this case where there's maybe a suggestion, but you can't really tell if there's metacarpal arthritis in the setting of a coronal split, I do my resection, as I mentioned, before I ever open the knee, and you can see the capitate through that coronal split once you do the proximal resection, and you can, under direct visualization, assess that cartilage surface. And while this has never happened to me, that is part of my algorithm, that if I were to see substantially degraded capitate through that split, I would abort that procedure and perform a salvage. I'm not sure that's the right thing to do, but I think out of humility, I'm 3 years into practice and still exercising relatively conservative indications.
Michelle?
I think that was a very important remark, and it makes me say that you have to do a procedure that you are confident with. I mean, you don't have to go home now and make this medial trochlear, femoral trochlear procedure, because you need to be an expert to have success with that. And that goes for everything. A very important part of clinical results is the surgeon and the surgeon's confidence with the procedure that he is performing.
Thank you. Thank you. Wise words is a good point to wrap things up. I want to thank all the panel again for a wonderful evening of discussion and discourse. I want to thank our fellows, Antonia and Adam, for their presentations. Thank the authors for coming to have their papers scrutinized, and our experts, and of course, Michelle. We're going to end the meeting now with a video that we will play regarding the next Journal Club meeting, and we hope to see you then.